All right, guys, welcome back. So today what we're going to be talking about is about medication errors and how to reduce your likelihood of actually having a medication error in your practice. Not a single person in this world got up and said, you know what, I can't wait to hurt a patient today. In fact, I think that as healthcare providers, excuse me, that's one of the things that we try the most to avoid. So we're going to spend some time today going over some different things. I've got our learning objectives up here listed. Remember, I give you the helpful icons in order for you to follow through the lecture so that you can make sure that you answer all of your learning objectives for today. The first thing we have to do is we have to kind of define what a medication error is. And I think sometimes people think, well, a med error is only a med error if it harms the patient. That's not the true definition. In fact, the true definition of it is whether any error that occurs in medication administration process, whether or not it harms the patient. So it doesn't even have to reach the patient. It can still be considered a medication error. The reason why we're so particular about this is that we used to live in a very punitive healthcare environment in which we would get in a lot of trouble if we had a med error. Now, not so much. In fact, one of the things that we try to do now is we try to say, listen, if there's a process that's wrong with this, you've got to come tell us, be forthright, be open, be honest, tell us what's going on so that we can actually develop processes so that we make sure that these errors don't reach another patient. There is this categorizing medication errors, though you'll see this very frequently used in different hospitals and different facilities. And for the most part, this is not meant to be punitive. This is not meant to be you're a bad nurse or you're a bad provider. Instead, this is meant to help us to understand what level it was. Please don't memorize this. This is really just for your information. Category A, did a medication error actually happen? Category B, did it reach the patient? So there's different levels of thought processes. I do want you to spend some time just kind of appreciating this chart and to understand that there's a lot of different ways that we're going to call a medication error a medication error. One of the things that happens in practice is that there are things that we do as healthcare providers, meaning nurses, doctors, paramedics, LVNs, RNs, APRNs, physician assistants, radiology technicians. All these people have the potential to have a medication error. So what are the things that we do as providers that actually cause these medication errors to actually happen? One of the things that we do is that we admit one of the rights of drug administration. And if you're sitting there and you're going, I don't remember what the rights of drug administration are, this is a great time to review them. So with reviewing those, remember there's 5 of them. I always remember them like this. To give them a lot of good medications, you got to be a real good tramp. Okay, time, route, amount, medication, and patient. Those are the rights of drug administration. Failing to perform an agency check system. So a lot of our organizations in town that I work with have gone to electronic scanning. So what happens is that you have a device. It's about the size. It looks like a scanning gun at Walmart. And what they'll do is that here. So we'll just pretend this mouse is a scanning device. You'll go into the patient's room, you'll scan their armband, and then that information goes into the computer. And then in order to give the medication, you actually have to scan the medication, and then that goes into the computer. That system of checks and balances, when they instituted that, we had a 75% decrease in medication errors across the country, okay? Just because we started scanning. The process took us a while to get down. It was a while because it was just one of those things that it just took time to learn. And I think because we were slowing down, that it really made a difference in how we were processing through okay, what's this medicine? It gave us more time to process and think. I will tell you that I've seen nurses who do not follow this process. They'll get 2 copies of the armband. They'll go take their machine into the medication room and do it at the medication room. Making these short checks, not following our agency system check policy, is going to increase your error rate. So be thinking about that whenever you feel like you need to shortcut a corner. Don't. All these processes are in place ultimately to help us to decrease our overall error rate. Remember, we spent a lot of time talking about pharmacokinetics and pharmacodynamics and things such as age and body size, renal, hepatic function. If we don't take those into consideration before we drop a pill into a patient or an IV into a patient or whatever route we're going to use, those really affect the patient, and ultimately we can hurt our patient because we didn't think about those factors before we went in there. The next thing is about verbal or phone orders. So in the past, it was pretty commonplace for physicians to call you up and say, hey, Jamie, I need you to give 232 amlodipine, increased amlodipine to 5 milligrams. And I would take out my pen and I would take out my piece of paper and I'd write that order and I'd write verbal order verified and I'd ship it off to the pharmacy. Well, what was happening was those verbal orders or phone orders can be misinterpreted. We can document wrong, we can transcribe it wrong. So now the best practice is whenever the physician wants to put in an order is for them to put it in electronically themselves. That way there's no question about what that order really was, the intention of that order. I will tell you that when we first started going to some of these systems like this, one of the failures that happened is the physician would have to go in there, and because they were not used to computer charting, there was a huge learning curve for them. So say for instance, there was a list of medications that would come up, and let's take amlodipine for example. So what would happen is that there'd be amlodipine and there'd be 3 different ones listed there. There'd be a 2.5, a 5, and a 10 milligram tablet. And the physician would have to select the correct dose that they wanted. But let's say it was a medication, let's do morphine instead, because morphine kind of has different things. Like with morphine, we give 10 milligrams, we can give 5 milligrams, we can give 2 milligrams, you can give 1 milligram. It all just kind of depends on what the patient needs. Well, what was happening is that the physician was choosing morphine 10 milligrams, but what he really wanted was morphine 2 milligrams, but what he had selected was 10, but his intention was 2. So it had a little bit of a catch-22. We had to make sure that the drug they were selecting and the dose that they were ordering were congruent. So it was a learning curve. So based upon that, CPOE ordering, meaning that we order these electronically now, has really made a huge difference in making sure that our patients are getting the correct dosages. The other thing that can really affect us as healthcare provider is working under very stressful work conditions. Guys, being any kind of a healthcare provider, whether you're a nurse, a physician, a pharmacist, a pharmacy tech, things can get really, really hectic in your day. You have lots of competing interests. So one of the things that I want you to be in the habit of is that when you're going to go give a patient medications, I want you to be in the zone. We're going to take a little hint here from our friend Marty the zebra. He is in the movie Madagascar. He says, if the zebra is in the zone, you leave him alone. Well, when you get in the zone to give medications, I want people to leave you alone. There are some practices in some hospitals now where they're drawing, so the medication dispensation system called the Pisces or the Diebold. I'll call ours, Pyxis or Diebold. I'll call ours the Diebold. The Diebold is a system where we can log in, see the patient's profile, and select the medications we want. Some hospitals have actually gone around where the nurse stands and put a box and said no talking zone. Some hospitals have gone one step even farther, and they make the nurse put on a vest when they're giving medications so that everyone knows that they're in the zone, leave them alone. When I go to the patient's room to give medications in the hospital, I like to decrease all of my distractions as much as possible. So I walk in and the Price is Right is on. I know you may not know this yet, but that is a sacred time when the Price is Right is on. I like to turn the TV completely off. I'm like, it's time to receive your medications. In order to increase your safety, I'm going to turn your TV off so that you can fully hear me. So I turn the TV off, I turn the lights on in the room, I set the patient up in the bed, I get in the zone to give medications. I have to carry around what's called an ASCOM. An ASCOM is like a telephone that anyone can reach you on. The ASCOM phone, I'm not going to answer it during medication pass. I may look at it to see what's there, but that's a distraction. So I try not to look at it at all when I'm giving medications. Again, I want that patient's full attention. I don't need them on their cell phone. I don't need them eating their breakfast. I need their eyes on me for this brief window of time so that we can get in the zone and make sure that they are completely taken care of. The other thing I want to make sure is that as a provider, as a healthcare provider, as a family nurse practitioner, and you as a nurse, these are some abbreviations that we are not supposed to use anymore. So when we're writing for units for insulin, we don't write the letter U, we actually write out the word units. Whenever I'm writing out the words SQ, subcutaneous, I should be writing out subcutaneous, not SQ, so forth and so on. So these are some abbreviations that if you saw them in someone's charting or in an order, you would want to have them clarified, because again, not supposed to be using them because they do lead to frequent errors. There are some things that, we kind of talked about what we do as nurses that cause problems. Well, now let's talk about what the clients do that cause problems. Your elderly population, they're going to have a primary care provider. They may have a specialist for their heart. They may have a specialist for their kidneys. They may have a nurse practitioner that they see in the primary care provider's office. There's so many people coming at them and handing them prescriptions, so they get confused. All right, so having drugs prescribed by several different providers can be an issue. Getting medications filled at more than one pharmacy. So I ran into a patient last week, and she had a prescription for Tessalon Pearls. Well, her physician had called the Tessalon Pearls into the Brookshire Brothers Pharmacy, but the Brookshire Brothers Pharmacy, this was a medication that was on their expensive list. So she had the prescription transferred from the Brookshire Brothers Pharmacy to the Walmart Pharmacy. Okay, sometimes your patients are going to do this. A lot of pharmacies have pharmacy programs that makes one medication cheaper here than over here. But again, now what we lose is because we don't all have a common charting system, a common pharmacology, a pharmacy system, that we're losing this data and this information, so we may not have all the dots and everything connected. Not filling a prescription. Why would you not fill a prescription that was given to you? I just don't understand. But I digress. Sometimes they get prescriptions and they just don't fill them, or they may be getting auto refills, which auto refills are great because they keep the patient, like with the medication, rolling, except when they get 3 different vials of the same medication or 3 different bottles of the same medication and they don't recognize it as being the same. So I had a patient recently that was taking Coreg, and in his little pill box, I noticed that there was a oval shaped tablet and a round shaped tablet, but there was one too many pills in each one of the boxes all week long and each one of the boxes all night long. And I'm like, So I got all of his medications out of the box and I started looking at them. He had Coreg 3.125 milligrams. It's a beta blocker. It's used to control heart rate and blood pressure. He had 2 bottles of Coreg 3.125. One was an oval tablet and the other one was a round tablet. And what we found was that he had been putting in an oval and a round tablet each morning and an oval and a round tablet each night. So that medication wasn't available. It wasn't possible for him to take that medication like that. Like it was too much. He was also taking 3.125 milligrams twice a day, and he was getting 6.4 milligrams twice a day. So he didn't feel very good. So very important that auto refills do happen, but we need to make sure that we can differentiate between bottle number 1 and bottle number 2. My idea with him was I took the Coreg and I rubber bandaged it together and I wrote a number 1 and a number 2. And we're going to fill out a bottle number 1 and then we'll fill out a bottle number 2. So again, taking medications incorrectly. Taking medications that are left over from a previous illness. None of us have any antibiotics in our cabinet, but sometimes they do. And so then they'll start taking medications from something else that may or may not be treating what they actually need to be treating. Taking medications prescribed for something else. I had a patient this last week, went into her home. She's like, I'm so short of breath. So I'm like, okay, honey, let's go take a neb treatment. So we go back to our neb treatments, and the patient's supposed to be on something called ipratropium albuterol, which is known as a duoneb, and supposed to be taking those 4 times a day. Well, her sister had extra medications that looked the same as hers, and so she was just taking those. She was just taking straight albuterol. Well, the problem with the COPD patient is they need both of those medications in order to feel better. They need the combo. It's called a duoneb. She wasn't taking the right medicine because she had gotten it from somebody else. So have to think about that sometimes. You have to ask yourself, what are they doing? When we have a medication error, it impacts not only the patient and, of course, our psychological health, it also affects our hospital systems. We get a pretty bad rap if we keep doing this over and over again. Okay? We can't do this. There is no acceptable amount of medication errors that is okay. I'll tell you, one of the things that's happened in healthcare now is that if your patient comes back into the hospital, they're admitted to the hospital, and they come back anytime within the next 30 days for any reason whatsoever, medication error, falls, whatever, there is absolutely from Medicare no reimbursement for that hospital visit. Yeah, you heard me. So a patient comes in, let's say they weren't taking their medications right at home and they had an exacerbation of their congestive heart failure. And then they go home and they mess up their Lasix and they're not taking it right and they're not being managed properly at home, and we have to readmit them to the hospital for fluid overload. If that patient is a Medicare patient, the hospital gets $0 of reimbursement. So we have to begin to think about our impact of medication errors, whether they are ours or the client's, and what that means for our hospital systems. Again, there's no acceptable okay of a medication error. It all has to be analyzed. It all has to figure out what's going on, what happened. We had a student that we were in clinical for 2 days, and the student and I, we had just gone to this computerized documentation system, and what happened is that the patient's blood sugars were like in the 200s. We were given like 5 units of insulin, 6 units of insulin, some pretty low doses of insulin. And we got back to work, just to clinicals the next day, and now the patient's blood sugars was like 350, 400. I'm like, what is going on? That was when we realized that the way that the medication administration record had been set up in the computer, it was not differentiating between a day sliding scale and a night sliding scale. And the only way that you would have known the difference between the two was that the insulin dosages were less during the night and more during the day. Well, the nurses had all figured it out, but the students and I had not. So one of the things that we had to do is we had to report ourselves. So we called the pharmacist, we talked, first off, we checked on the patient. Second, we notified our charge nurse. Third, we had to write up an incident report and we had to document all that had happened. Then the other thing that we did was we actually contacted pharmacy and explained to them what our error of understanding was. Because our error of understanding we were able to show them what we had done, they actually changed the whole process for how those medication records or orders showed up on the MAR. So documenting in a very factual manner, telling them, hey, this is what's happened. We had to call the physician. We had to we got on the right sliding scale, and then we saw a drastic improvement in the client's blood sugar. But we had to slow down, think through, and of course we had to report everything that we had done in order to mitigate this issue with the client. An incident report, again, it's not part of the hospital's record. It is part of a risk management profile. When they came to us, they helped us to understand and then kind of find out when they went back and did an audit of several charts of insulin. This was happening across the house, across hospital-wide. we call it housewide, happening across hospital-wide, and because of that, a change in the policy and the way that the insulin order showed up on the computer resulted because of that. Whenever we figured out that we had made an error, we had to make sure that there was no harm that came to the patient. So we were documenting that, the patient never lost consciousness, that the only risk to the patient was that the blood sugar was elevated for less than 24 hours. And then we used this to help to improve, ultimately, a better outcome for all patients. By drilling down, we were really able to drill down to this root cause analysis and to see this is what happened and this is the way that you can prevent this error in the future. There is something called a sentinel event. This is when we have an unexpected occurrence involving death or serious physical or psychological injury. These are always more serious. So our patient didn't really suffer from our administration error, but nothing happened to him. He went on with life as normal. However, a sentinel event is a lot more serious. It's a lot more elevated. So these are always investigated, and then there are steps put in place in order to make sure that there is no repeat incident with this. Sentinel events can be really, really serious. I can think of malfunctioning OR equipment where a patient got electrocuted. We had a couple of, I'm going to say a couple, those really weren't sentinel events. We had some issues a couple of years ago with some medications IV that were causing some unexpected errors. And it was basically, it was Phenergan, and they pulled Phenergan off the market for a brief amount of time period because they found that it had an additive in it that they had used in manufacturing production that was causing patients to have extrapyramidal side effects, which doesn't normally happen. So whenever we are thinking about how we can reduce errors as nurses, there's a couple of things that we need to do. We need to think through our nursing process. So first thing we do before we ever walk in there is that we have to assess these patients appropriately. Assessing a patient needs to be thorough, and it needs to include all the following elements. And sometimes we have to ask these questions several different times from patients in order to get the answers that we want. So be sure that you're following these steps during your assessments, and yet you need to make sure that you are doing this every single time. Do you have any allergies to food or medicines? Tell me about your past medical history. Have you ever had any surgeries? Tell me what medicines that you take, both over-the-counter, herbal supplements, and those that were prescribed to you by a physician. Okay, hang on just a second. Let me go look at your laboratory data. I'm specifically looking at renal and liver enzymes. And of course, there's others plus, but renal, liver, electrolytes. I'm going to look at your physical assessment findings. I'm going to go in and do my physical exam on this patient, walk through all that so that I can see what's going on with this patient. And then I need to see what you, patient, know about your medications so that I can understand what your level of understanding is. The more educated your patient is about their medicines, the more likely they are to be compliant. Remember, now we're to the planning stage of our health assessment. We're not going to use any of those weird abbreviations. We're just not. We're going to stay away from the no-no list. If you don't understand a physician's order, you're going to absolutely ask for clarification. This is a great way to use the SBAR format. So the SBAR format is a communication tool. It's called Situation, Background, Action, Assessment, and Recommendation. So we use those four things in order to kind of talk to physicians, talk to those upper level providers in order to make sure that they understand. So the situation is that I have a patient in room 343. She's complaining about constipation. The background is that she's been taking a narcotic pain medication for her pain after her C-section. I have tried giving her prune juice, I have tried walking her, and I have tried giving her fruit, foods high in fiber. My recommendation is that we add a stool softener to her daily plan so that we can prevent any future constipation. Okay, that's what an SBAR does. We absolutely, we do not accept any verbal orders. if possible. Okay. I say if possible because I work in the emergency department as a registered nurse sometimes. And there are times when a physician kind of like blah, 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 blah. And I'm like, okay, make sure you put that order in the computer. Okay. So I'll take a verbal order, but they've got to put it in the computer so that I can actually physically document on it. So very important that we try not to take verbal orders if at all possible. But if we have to, we can. But again, I really want the physician, the upper level provider, putting in their own orders. Our facilities, our hospitals that we work for, they want to have a zero medication error issue in their hospital. They set policies in place in order to help provide safety to the patients. Okay. So again, I have seen nurses in the past who like to print 2 armbands, they take the scanner into the med room. No, this procedure is meant to be done at the bedside. It's meant to be a safety thing. It's meant to have the patient help me out. I tell the patients all the time, I'm like, look, I know you're gonna get really annoyed by me asking you this, but every person from me to the end of time that provides you healthcare and gives you medications should be saying, can you tell me your full name? Tell me your date of birth. All right. And then today I have for you Tylenol. Tylenol is a medication that helps to provide pain relief. This medication is expected to work within 30 to 45 minutes and should provide mild pain relief. Right now, if your pain is recorded at a 7, we hope that this medication brings your pain down to about a 5. Okay, so I give them all that education right up front about that. And then I'm going to say, okay, now patient, as part of my healthcare team, you got to tell me what I just told you. What do you know about Tylenol now? Okay, that's part of it. They're part of my plan. They're part of my way of keeping them healthy as if we all participate together. Here we are to the implementation phase of the nursing process in our medication administration world. Remember, if the zebra is in the zone, you leave him alone. Okay, so minimize your distractions and go through those 5 rights of medication administration every single time you're giving a medication. You will reduce your errors and medication. Remember that we always ask the patient to verify their name and their birth date. Those are usually 2 things that they know. You're going to get into situations in which the patient is unconscious or unaware. I will tell you what I've done in the past is I look at their armband that was provided to them by the hospital. If there's a family member or a friend, I'm like, is this Richard Nixon? And is his date of birth 10/13/52? And I have the family verify. I always make sure that when I'm looking through my medication records, if I'm given Benadryl, 25 milligrams IV times 1 dose now, then I make sure that that is a correct dose. Before I give that patient that dose of Benadryl, I'm going to look it up in here in my drug book. I can't look up Benadryl because that's the brand name, but I can look up the generic name of it, which is diphenhydramine. When I look up diphenhydramine in the book, it tells me what the correct dosage is. It tells me what I can expect from a therapeutic response. It tells me what it's used for. It tells me what its unlabeled use is, reasons why I shouldn't give it, contraindications. It tells me cautious use. It tells me the correct dosage for this patient. Okay. It tells me what I need to know if I give it IV versus PO. It's all in the drug book. I'm going to make sure that when I have to calculate a dosage, especially if it's a pediatric or an elderly patient, I'm going to have those dosage verified. If it's a medication that can cause harm quickly, meaning that it can affect heart rate, blood pressure, pulse, I'm going to have someone verify my dosages. When I go to the bedside, I verify the patient name. I've done all my research. I scan their armband. I scan the drug. I'm ready to give the drug, open it up at the bedside. I don't open it up in the med room. I open it up at the bedside. And then as soon as I'm done, click, 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 I finish my documentation so that everyone on the floor knows that I've given that medication. One of the scariest things that's ever happened to me was I had a friend who said, hey, I'm going to go give you your patient's medications in 20. And I said, okay. And then I looked back on my documentation system and it still showed that the patient's medicines hadn't been given. So I went to the Diebold to pull the medications and something in the back of my head says you need to check. And so what I did was I hit patient usage and I could see that she had dropped the medications out of the Diebold, but it wasn't documented. That patient almost got double dipped, almost got double medication administered to them because I wasn't paying attention. So remember that. Remember that whenever we give medications, we want to make sure that they actually swallow them. Now, I know this isn't normally a problem that we have with a lot of our patients, but sometimes they'll cheek them or they'll put them under their tongue, especially in patients who are having cognitive impairment, meaning that they're not thinking correctly. So you're going to have them go, okay, and watch them physically swallow the medication. Don't just hand the patient the medication and turn around and walk out of the room. You'll come back hours later and your pills will still be sitting there. Don't do that. Always be looking for things on medication that like LA, XL, XR, SR. Those all mean that that medication has an extra long-acting formulation. Usually medications that have LA, XL, XR, or SR are only given once a day. They're usually not given twice a day because they have a long-acting response. So therefore, we don't have to do as frequent of a dosing. We need to assess our patient after we give the medication. Okay, we went through all this process of getting them there. We've got to follow up and make sure that we actually are getting the desired outcome that we thought we were going to get. If I give a blood pressure medicine, within the hour, I need to be back in there reassessing that blood pressure to make sure that it's going the right direction. Okay. I've had students all the time, they come up to me and they're like, Ms. Hardy, my patient's blood pressure is 170/90. I'm like, great, let's go give some medicine. What do you got? And we look at the MAR and maybe there's some amlodipine or some hydrochlorothiazide. I'm like, those are some good medicines, let's give those. And then about an hour or so later, I'm like, so how's your patient's blood pressure? And they're like, I haven't checked. Go check, woman, go check. Okay, we need to know that if what we did actually worked. So important that we do that. We also want to know that if we give a patient a medication, is there any kind of adverse effects that happen with this? I have a friend and they have like the oddest family as far as like medications are concerned. They can really have some weird reactions. The weird reactions can be everything from like, Benadryl makes normal people sleepy. No, it wires them, but you give them 2 Tylenol and they're out for days. They're just weird. So those are some of those adverse effects or just some side effects that we really need to be kind of paying close attention to. Some medications cause side effects, nausea, vomiting. I don't know about you, but I hate to be nauseated. So always check on your patient to make sure that those issues that they're having are cleared up, or if they are having an issue that you're addressing it. Again, this is just another of those slides that just kind of shows you about how we categorize med errors. Again, do not memorize this, okay? This would be for in-hospital use only. Nursing and errors. Here's the most frequent reason why we make errors. Administering the improper dose, giving the wrong drug, please don't ever do that, or maybe even the wrong route of administration. I had a physician one time, he gave me an order to give a medication IV, but that's not what he meant. I didn't know that's not what he meant, and I gave the medication IV, and the patient did not feel very good for a little while because we gave the medication IV. It was a medication that was to be given IV. It could be given IV, but in this circumstance, it wasn't appropriate use. So always check your route of administration and make sure that the route that has been ordered makes sense for the situation. So if you have a patient who has a high blood pressure, it may make sense to give a blood pressure medicine IV. But if the blood pressure is normal, giving the medication IV may not make a lot of sense at that point in time. Remember, there are a ton of resources. So I've given you a couple already, but I'll tell you. So this is on your phone. There's an app for that. I created a folder of all my medical apps. I use Epocrates, which is a free drug app. And then I also use NPR, another free drug app. I like the program Skyscape. Skyscape, you can look it up, SKYSCAP, and you can actually purchase resources. You can actually purchase resources on your phone for use for every day. So Skyscape, for instance, I have a drug book in here. I have an IV drug book, and it also comes with a free drug index that you can look up drug medications in as well. So some of the stuff is free, some stuff you have to purchase, but a lot of stuff is free now, which is great. And of course, you also have the Wide Wide World Web. Our very young and our very old patients, these are the ones that where the most of the medication errors do occur at. And again, we kind of talked about some of the reasons, the polypharmacy, the multiple pharmacies, the multiple providers. These are all vulnerable populations. So when you're giving medications to these people, think, stop. Okay, be like the zebra, get in the zone. Medication reconciliation. This is how we keep track of patients' medications as they proceed from one healthcare provider to another. This is one of the most important things that I do in my life right now, is I try to make sure that the patient that they know what they're on and that they are taking everything that they're supposed to be taking. One of my greatest resources is I call the patient's pharmacies. I'm like, what pharmacies are you using? And I call the pharmacies, excuse me, and I get all their medications that they're taking from all their different providers. I've even been known to been like, okay, which pharmacy are you at? Walgreens. And I'll go by there and print up a med reconciliation list. And then we can actually see what everyone else is prescribing. And then we can make sure that the patient's taking it appropriately, because sometimes that is, it is a trial, okay? Anytime a patient comes into the hospital, we'll also do a medication reconciliation list. Typically, the patients either have them on their phone, they have a copy of them in their wallets. They're going to have this somewhere, we hope, so that they can tell us all the medicines they're taking. I tell my patients, I'm like, look, put your med list in your phone, because you'll lose a paper copy, but you won't lose your phone. There is an app for that too. There are a couple of different free apps. And in fact, a lot of times whenever the patient has like United Healthcare, Blue Cross Blue Shield, you can put the medication straight in their app. Super cool. Scott and White has an app where the patient can actually go in and see their entire medical record. So super helpful when you have patients who are traveling from out of town, or you just have to figure out what's going on. It's super helpful. I ran into a gentleman yesterday. He told me that. He goes, look, I have everything right here on my phone. You want to see it? And sure enough, he pulled up his app and there was all of his lab data and everything. It was fantastic. Remember to keep it simple, okay? To use a teach back method. I had a patient, again, you're so tired of my patient stories. I had a patient that I've been working with now for about 6 weeks, and we sat down for him to fill his medication box out. And as we're filling the medication box, we have all the pills in front of us. We have the little planner thing sitting there. And I said, okay, this is the metformin. It's 500 milligrams. I marked that you're going to take it morning and you're going to take it night. I said, so now which one is that? He goes, I can't read. I've been working with this guy for 6 weeks and I'm just now figuring out that he can't read. I had been writing all sorts of things down for him on note cards. So for him, using some visual aids to help him refill his own medical box. So went to Walmart and I bought the little stickers, okay, the little reward stickers, the silver stars that you used to get as a child, and we put one silver star on the metformin on the bottle and one sticker on the medication administration record. Now he knows that drug is his metformin. Otherwise, he couldn't read. So be thinking about those audio-visual teaching aids that you can do. Again, use the patient's phone against them. Go in here and set up a daily reminder to go off at 9 a.m. and 9 p.m. when you want the patient to take their medications. Okay, ding, ding. And then they're like, oh, okay. The whole Pavlov dog thing, we can do it with their phone. And then also we want to make sure the patient has a good contact information. I am utterly surprised at the number of patients that I encounter that don't know who all their physicians are or how to get a hold of them. So it's very important that they understand how to get people where they need to be, who their pharmacist is, that sort of information. I want my client to be able to name all their medications, tell me about their side effects, tell me how they're going to administer it. I want to watch them administer it. I want them to learn how to read a label intelligently. I want them to carry a list with them at all times. And I want them to ask me questions. The only way that you're going to get a patient to be that open with you is that you have to continually ask questions of them in order to kind of dig this information out of them and to get them to do that teach back with you. In our hospitals, we have different things that are helping us to reduce medication errors. We've already talked about a lot about these. One of the most important things, guys, that you'll ever do to reduce your medication error is to follow your hospital policy. It's not put there to irritate you. It's not put there to make you work slower, to make your life harder. It's put there ultimately to help protect the patient's safety. So follow your hospital guidelines. We have lots of different things that tell us about procedures and policies about where, how, where, what we can do in the hospital in order to help keep medications safe. We want medications stored correctly. We don't want insulin. We want insulin to be in the refrigerator. We want, insulin that's not being used to be in the refrigerator. We want to have appropriate labels on them. We don't want to take pills out of their original packaging, like the little blister packs from the pharmacy in the hospital, and then put them someplace else. We want to keep everything together. We don't want in our facilities to have thousands of pills of hydrochlorothiazide. We want to have what we're going to use for the day so that we're not being wasteful and having to throw away a whole bunch if they're not going to get used. We want our patients to follow the same thing when they're at home. We don't want them to have just thousands of pills laying around because they're going to get confused. Remember, there is a no-no list of abbreviations. Do not use the no-no list. And then don't be like me. Okay, I already confessed that this is the 2012 version. I need to go get a new drug book. I just haven't done it yet. Okay, I promise. I'm gonna get a new drug book this year. I promise. A couple different places that you can help with track medications. FDA is MedWatch. And then I love the Institute of Safe Medication Practices. It's an incredible website all dedicated to helping us as nurses, doctors, physicians, PAs, paramedics, LVNs, rad techs, everyone who gives medications, all about making our processes safer in order to make sure that those errors don't translate to the patient. So if you get a chance, look up the Institute for Safe Medication Practices. They actually will send you free emails about medications updates. Really super useful. And then of course, MedMarks, you can anonymously report any issues that you're having.